I now propose that we go into public session. Is that agreed? The purpose of this morning's meeting is to meet with mental health reform and with the Inspector of Mental Services in relation to developments in the mental health service area. On behalf of the committee, I would like to welcome Ms. Kate Frowin, Senior Regulatory Manager, Dr. Susan Finnerty, Inspector of Mental Health Services, and Ms. Rosemary Smith, Director of Standards and Quality. And in relation to mental health reform, Dr. Sherry McDade, Director, and Ms. Kate Mitchell, Senior Policy and Research Officer. Thank you very much for attending. I wish to draw your attention to the fact that by virtue of Section 17(2)(l) of the Defamation Act 2009, witnesses are protected by absolute privilege in respect to their evidence to this committee. However, if you are directed by the committee to cease giving evidence in relation to a particular matter and you continue to do so, you are entitled thereafter only to qualified privilege in respect of your evidence. You are directed that only evidence connected with the subject matter of these proceedings is to be given, and you are asked to respect the parliamentary practice to the effect that, where possible, you should not criticise or make charges against any persons or entity by name or in such a way as to make him or her identifiable. I also wish to advise you that any opening statements you have made to the committee may be published on the committee's website after this meeting. Members are reminded of the long-standing parliamentary practice to the effect that they should not comment on, criticise or make charges against a person outside of the Houses or an official either by name or in such a way as to make him or her identifiable. Can I now ask Dr. Finnerty to make your opening statement? Thank you.
Thank you. I welcome this opportunity to make this submission. The Mental Health Commission is the regulator for mental health services in Ireland. We are an independent statutory body that was established in April 2001 under the Mental Health Act, and the role of the inspector is set out under the Mental Health Act. 90% of mental health services are delivered in primary care settings. A further 10% are delivered within specialist mental health services, including community residences. Under the 2001 Act, the statutory scope of mental health regulation is limited to inpatients only, which are estimated to make up less than 1% of mental health services in Ireland. The Joint Committee has sought information on developments in mental health services in the state. The basis of this report is taken from recent inspection findings, as well as information compiled by the Commission as part of our ongoing monitoring of compliance and receipt of quality and safety notifications from services. While the scope of the Commission's regulation is limited, we nevertheless closely monitor developments across the broad range of mental health services in Ireland, including acute, adult mental health services, rehabilitation, continuing care, child and adolescent mental health services, forensic mental health services, and community mental health services. As a general comment, it is evident that the provision of mental health services is inconsistent across the country and lacks proper integration. For example, a young person in need of mental health services in Galway will be able to access a vastly different range and a level of services than a young person in Waterford. Similarly, a person in Cavan Monaghan or Sligo Leitrim will have access to mental health rehabilitation services, while a person in Donegal will not, even though they're in the same CHO. The Commission welcomes the implementation of Sláinte Care, therefore, which envisages a system of integrated care provided based on need and not location, age or diagnosis. We hope that this will finally realise the goals included for a Vision for Change, which set out the government policy 13 years ago in 2006. We understand a Vision for Change is currently undergoing a review and refresh and look forward to seeing the revised policy. In regulated services, we have seen a number of positive developments. We have seen the overall increase in the national average compliance with regulatory requirements from 74% in 2016 to 76% in 2017 and 79% in 2018. Progress is slow, but is consistently trending in the right direction. For the most part, we have seen good engagement from services in working towards compliance and implementing the Judgment Support Framework, which is the Mental Health Commission's quality framework. There have been some notable improvements. For example, the Department of Psychiatry in Roscommon University Hospital, who went from 52% compliant with regulatory requirements in 2017 to 83% in 2018. Another marked improvement was St Bridget's Hospital in RD, that went from 64% in 2017 to 93% in 2018. We've also seen some improvements in fundamental aspects of care provision, such as medication management, individual care planning, and consent procedures for involuntary patients. These are positive developments, but are not consistent across the country. There is work yet to be done to ensure people receive the same consistent, high-quality care and treatment, no matter where they are located. There has been ongoing progress towards decommissioning outdated and unsuitable buildings for the provision of inpatient services. In 2006, 17 approved centres were operating in inappropriate institutional settings. By 2019, only 3 remain, 2 of which had closed by 2020. We are having ongoing concerns. The Commission continues to highlight concerns in relation to the physical infrastructure of mental health facilities and premises. Inspection reports have consistently identified concerns relating to the overall suitability of premises to meet patients' needs, concerns relating to the physical safety of premises, and concerns relating to the maintenance of premises, namely basic repair works and cleanliness. In 2018, 70% of regulated services were found to be non-compliant with the regulatory requirements relating to their premises. I find it unacceptable that in 2019 we still find service users in long-stay units living in dormitory-style accommodation, units where there is 1 shower shared between 20 people, and to find units which are dirty and in disrepair. This does not respect the basic privacy and dignity of service users. It is the position of the Commission that there is no therapeutic benefit to the use of restrictive practices such as seclusion or physical restraint. These practices should only ever be used as a last resort where there is a serious and urgent safety concern. Despite this, physical restraint was used in 81% of all approved centres in 2018 and 97% of acute adult services. Seclusion was used in 42% of all approved centres in 2018 and 65% of acute adult services. We are concerned that there is a lingering complacency in the use of these practices. In many services, these practices are accepted and commonplace. Such practices directly affect a person's human rights to liberty, autonomy and bodily integrity. We have seen little real engagement in the proper scrutiny and reduction of these practices by the mental health services. In a recent report, I highlighted serious concerns in relation to the provision of general health services to persons with a severe mental illness in continuing care approved centres. People with a severe mental illness will die on average 20 years earlier than the general population for largely preventable reasons unrelated to their mental illness. Following a review of 10 services across the country, I highlighted inadequate and inconsistent monitoring of patients' physical health needs and inadequate and inequitable access to essential healthcare services. The Commission has sought a national response from the HSE to address these serious concerns. I also have concerns about the provision of specialist rehabilitation and recovery services for people with enduring mental illness. This can be summarised as a lack of appropriate housing for people to move to more independent living, too few rehabilitation teams, only 48% of the number recommended by Vision for Change, existing teams which are poorly staffed, and a lack of localised community and inpatient specialist rehabilitation units. We have a large number of people who are still residing in institutional care who, with rehabilitation and recovery services, could lead a more autonomous, satisfying lives as part of their community. While the statutory scope of the mental health regulation is limited to inpatient services, as the inspector, I have the statutory power to visit and inspect any premises where mental health services may be provided. Over the past 3 years, I have undertaken a systematic review of all 24-hour staffed community residences in the state. There are 118 such community residences across 9 HSE community healthcare organisation areas, accommodating over 1,200 service users. The residents of these services are often in long-term accommodation, and the community residence is their only home. They represent a large number of potentially vulnerable adults with enduring mental illness whose voice is rarely heard. The community residents are often poorly maintained, too big, institutionalised, restrictive, and at times not respectful of the service users' privacy, dignity and autonomy. Many residents were in poor physical condition, with 19% of those inspected in 2008 requiring urgent maintenance and refurbishment. A significant number of people living in these residences should, with appropriate support, move to smaller, less institutionalised accommodation. These units remain without regulatory oversight or safeguards, despite the number of units and the vulnerability of service users accommodated in such units. Over a number of years, the Mental Health Commission has called for these residences to be regulated. Regulation would allow the Mental Health Commission to enforce changes where deficits and risks are found, protect the human rights of people living in these residences, and help mental health services to provide care and treatment in accordance with best practice standards. At the end of 2017, I reviewed the provision of child and adolescent mental health services, CAMS. This review highlighted a number of concerns about the provision of CAMS nationally. These include poorly staffed community teams. Overall, the staffing in 2017 was 60% of that recommended by Vision of Change. The number of young people admitted to adult units, which the Commission had continued to raise as a concern across a number of years. The variation in funding for CAMS across CHOs, which varies between €40 per capita in CHO5 to €92 per capita in CHO2. The lack of out-of-hours emergency CAMS, both for the assessment and for the inpatient beds, and waiting times up to 15 months for non-urgent outpatient appointments with CAMS teams. The Commission recommends national oversight and governance to address the ongoing concerns within the regulated mental health services, noting that the ongoing and widespread nature of the concerns point to systemic issues that will not be addressed with a solely local or regional basis. The Commission recommends the revised National Mental Health Policy, A Vision for Change, should reflect the aims set out in Sláinte Care, in particular a focus on the provision of integrated care based on need and not on location or age or diagnosis. The Commission recommends putting proper regulatory safeguards in place to uphold the human rights and to ensure the safety and well-being of persons in specialist community-based residential mental health services, i.e. the 24-hour nurse-supervised community residences. The Commission recommends the establishment of an out-of-hours mental health service for young people in crisis, including a clear pathway for their families and loved ones. The Commission recommends the proper provision of funding to ensure that there are adequate services for persons with severe and enduring mental illness, including appropriate accommodation, general health and rehabilitation services. The Commission recommends the prioritisation of funding to ensure all accommodation and residential mental health services, i.e. approved centres and community residences, are safe and fit for purpose. Thank you.
Thank you very much, Dr. Finnerty. And now we would like to ask Dr. Sherry McDade to make your opening statement. Thank you.
Thank you, Chair, and good morning. And I'd like to thank the Chair and the members of the committee for inviting mental health reform to appear before you today to discuss developments in mental health services in Ireland. And we would like to welcome the attention being given by the committee to the area of mental health. By way of background, just briefly to highlight the prevalence and impact of mental health difficulties in Ireland is significant and growing. And 1 in 10 adults in this country has a mental health difficulty at any one time, and almost 20% of young people aged 19 to 24 and 15% of children aged 11 to 13 have experienced a diagnosable mental health disorder at some point in their young lives. The number of people disabled by a mental health difficulty is also growing at an alarming rate, with a jump of almost 30% between the censuses of 2011 and 2016 of people who reported a level of mental health difficulty that was disabling. Importantly, such mental health difficulties can be more debilitating than most chronic physical health conditions. For example, in Ireland, people with a mental health disability are 9 times more likely to be outside the labour force than the general population, and this is the highest proportion of people of those with disabilities outside of the labour force of any other group of individuals with a disability. The cost of mental health difficulties to this country is enormous, with figures suggesting this may amount to as much as 4% or more of GDP. This would equate to approximately €12.4 billion based on Irish figures. Now, to put this in context, a research study on the cost of childhood overweight and obesity estimated the total lifetime cost in the Republic of Ireland to be €4.6 billion per annum. So as you can see, mental health contributes a huge amount in terms of costs, that is untreated mental health difficulties. And so going forward, it is imperative that mental health is recognized and afforded appropriate priority within the wider health agenda to reflect its significance in contributing to the burden of disease in Ireland. And this will require a substantial increase in mental health funding, including in Budget 2020, to both sustain existing levels of service and develop new mental health services and supports. Now, this morning I would like to draw your attention to three major issues of concern. They are governance and accountability in the mental health services, the protracted delays in reform of Ireland's Mental Health Act 2001, and the implementation of national mental health policy. Now, it's very important to acknowledge the positive developments that have been achieved across the mental health system at local, regional, and national levels. And mental health reform recognizes the dedicated work of government, its agencies, public representatives, service providers, and the community and voluntary sector. And some of the achievements that we recognize include the development of clinical care programs in areas such as self-harm, eating disorders, and early intervention in psychosis, the introduction of a national framework for recovery in mental health, and pilot of an advocacy service in child and adolescent mental health services. Some positive developments that have been initiated at primary care level with the introduction of assistant psychologists and the expansion of jigsaw services and the piloting of e-mental health supports. Mental health has also received significant attention in the Oireachtas through Shannon and Dáil debates, and most significantly through the establishment of the Oireachtas Committee on the Future of Mental Health Care. And while all of this progress is welcome, it is taking place in the context of new challenges. Firstly, the Irish mental health system suffers from a severe lack of capacity in the face of increased demand, which has pushed the mental health services to breaking point. While efforts have been made in recent years to make up for some of the losses, the old adage of mental health as the Cinderella of the health services is still evident in the continued under-resourcing in mental health services and supports. The shortfalls in mental health service delivery are further reflected in the lack of out-of-hours crisis services for both adults and children. We are disappointed that despite the recruitment of new staff as part of a planned rollout of 7-day services across adult community mental health teams, only 4 additional areas are reporting a 7-day-a-week service since this effort to roll out the services was initiated. And as of April 2019, HSE Mental Health confirmed that there is currently no planned date for completion of the cost and implementation plan for providing 7-day child and adolescent mental health services. So not only are the child and adolescent mental health services not able to provide 24/7 support around the country, but there's not even a date for producing a plan to see how that can happen. A participant in Mental Health Reform's national consultation, the My Voice Matters consultation, noted that outside of office hours, there's no professional to turn to when in crisis. At the weekend, for example, it makes no sense that people in this day and age still have to go to A&E as a first resort. It doesn't help patients. The Inspector for Mental Health Services has recently reported appalling standards in certain mental health inpatient units, and the Mental Health Commission has recently published a report on the lack of physical health care monitoring of individuals in a number of inpatient services across the country. There are a myriad of other gaps in mental health service provision, including a lack of resources in CAMS, which has a fundamental impact on access and quality of care. As of September 2018, which is the most recent figures we were able to identify, almost 2,500 children were on the waiting list for CAMS, of which over 12% were waiting more than 12 months. Lengthy waiting lists also exist in primary care psychology, and there are significant challenges for particular client groups to get access to mental health services, including those experiencing homelessness and those from ethnic minority communities. We are also deeply concerned with reports from service users of poor quality in mental health services. Our national My Voice Matters surveys found that over 40% of service users indicated that they had a poor experience of HSE mental health services. Almost 40% indicated that they were not involved as much as they would like to be in decisions about the medication they take. 2/3 reported that they did not have a written recovery or care plan developed with their community mental health team. And among family, friends, and carers and supporters, over 70% were dissatisfied with the extent to which HSE mental health services had considered their support needs. So, notwithstanding the resource issues, we would draw a direct link between those and the experience and the quality of the services being able to be provided. In terms of governance and accountability, we would acknowledge that between 2013 and 2018, there has been an increase of approximately 20% in the mental health budget and 28% in terms of mental health spend. Notwithstanding such progress, and it's important to acknowledge as well that that still has not brought us to the same level of funding that was being provided in 2008, before any implementation of a vision for change had ever taken place. Notwithstanding such progress, investment in mental health services continues to fall well below national and international standards. And in 2019, just 6% of the total health budget was allocated to mental health, representing an ongoing trend in recent years of a significant underinvestment. Sláintecare recommends that mental health spending increase to 10% of overall health spend. And in a report prepared for the Department of Health by the Work Research Centre, they identified that a comparative positioning of Ireland internationally suggests that the percentage resource allocation today is lower than in some of the countries with better developed and better performing mental health care systems. And that data available indicates levels of allocation of between 10 to 30% in countries such as Sweden, the Netherlands, Germany, France, and the UK. Recent developments to invest in Ireland's forensic mental health services and the introduction of the Service Reform Fund in the HSE, including the national rollout of evidence-based approach to supported employment for people with severe and enduring mental health difficulties, are welcome. However, investment in mental health services and supports must continue and must be increased on a much greater scale in order to effectively improve the mental health outcomes of Ireland's population. And we recommend that public expenditure be increased to 10% of the health budget within 10 years to be in line with international standards on mental health funding as a proportion of the overall health budget. In addition to this situation, there continues to be no national mental health information system to report on the full extent of resources, provision, quality, and outcomes for community-based mental health service delivery. For example, there's no data on the number of people in community mental health services who have an individual care plan, on the number of individuals offered a talking therapy, on the waiting times for such therapies within mental health services, and on the employment and housing outcomes for people using the mental health services. Mental health reform has been calling for such a system in budget submissions since 2013. It is not acceptable that more than 13 years after publication of a vision for change, there is no information system to account for the almost €1 billion in public expenditure on mental health care each year. And we recommend that an interim system for gathering key performance information on the mental health services be put in place as a matter of urgency. We note the restructuring of the HSE governance and accountability structures in 2018 led to the dissolution of the HSE's mental health division and the abolition of the post of National Director of Mental Health. And despite the appointment of senior management officials responsible for leading on mental health operations and mental health service planning and strategy, it must be considered that the dissolution of these structures within the HSE on mental health may have an adverse effect on driving the reforms necessary to ensure the delivery of a modern recovery-focused mental health system that adequately protects the human rights of adults and children. And so we recommend the post of National Director for Mental Health and the Office of the Mental Health Division be restored to ensure coherent leadership in mental health at the national level and to ensure clear authority and accountability for a distinct national mental health budget each year. With regard to the mental health legislation, we have consistently advocated for reform of Ireland's Mental Health Act in line with the expert group recommendations on review of the 2001 Act to ensure that people have their rights adequately protected when they go into hospital for mental health care. The Minister has recently announced that the general scheme of the bill on reform of the 2001 Act will be complete in June 2019. And ready for the Mental Health Commission's consideration. Given the lengthy delay so far, noting that the expert group report was published in March of 2015, we are asking for a date for publication of the full reforming legislation, and that legislation be published before the end of 2019. It is also of fundamental importance that the Mental Health Amendment Act 2018, which was signed into law by our President in May 2018, is commenced as a matter of priority to ensure that those small but significant changes can be immediately made to the Act. This includes that people are encouraged and supported to make their own decisions about their mental health care. Finally, implementation of the National Mental Health Policy is, of course, a concern. Significantly, the oversight group tasked with reviewing Ireland's current National Mental Health Policy is due to complete their work, and the publication of their report is imminent. And in accordance with the terms of reference of the group, it can be expected that there will be a much greater focus on early intervention and prevention, mental health and primary care, improved access to mental health services, the development of services to appropriately meet the needs of particular groups of people, that is, individuals experiencing homelessness, people from ethnic minority communities, those engaged with the criminal justice system, and that it will have a focus on the social inclusion of people with mental health difficulties. Many stakeholders were disappointed. That is perhaps an understatement to say many stakeholders were disappointed at the pace of implementation of a vision for change. It is imperative that the revised mental health policy is supported by a costed and timelined implementation plan and the establishment of robust monitoring and review mechanisms. Finally, I would just like to conclude this statement with the thought of one of the participants in the My Voice Matters survey, who said, "It has been 7 years since my first contact with the mental health services before I have gotten the help I need, which I do feel the course of time waiting made a lot of things worse in my life." Thank you for your time, and I look forward to your questions.
Thank you very much, Dr. McDade. So we're now going to open the meeting to our members, and our first contributor is Deputy Margaret Murphy.
Thank you, Chair. I'd like to start by welcoming you all here this morning, and it's great yet again to see a full panel of lady, female witnesses, so you're extra welcome. Just, I suppose, a few general points first and questions. Because of the Darkness into Light walk which was held lately, I think the whole issue of mental health has really come to the fore, and I suppose people are, because of that walk, were sharing their stories more than they would have normally. So I suppose I'd just like to acknowledge everyone who took part in the walk and those who organised it. Can I just ask you, please, what do you think can be done to further decrease the stigma of mental health issues? And would you have any ideas of how maybe something could be put into the education system, particularly in national school, that, you know, a child growing up and becoming an adult realises that it is okay not to be okay, and that they would never think otherwise. You know, if we start young, obviously the wheel turns and those children become adults, and I suppose it's a win-win situation in that the people they'll feel better, and as well as that, it's cost effective in that it won't cost the health system as much for treatment, etc. So that's one question, please. And another one is, I suppose in both submissions there was a lot of questions there. So do you meet with Minister Daly often? And I suppose what what are his answers to those questions? Please, I have a few more then after.
Thank you, Deputy Murphy. Dr. Finnerty.
The question about stigma, I think quite a lot has been done to decrease the stigma. I suppose my concern would be stigma surrounding serious mental illness. I feel that hasn't been tackled as enthusiastically as it might be. I think people who have a serious mental illness and need maybe inpatient care from time to time, or who need help with vocation, with accommodation, do come across stigma. And I think it's to do with the lack of education about mental illness, and especially serious mental illness. And I think that people don't realise that people who have a serious mental illness do recover, and can live lives in the community the same as any other citizen. And that I think that I think the way to actually tackle that is more education, more publicity probably around the fact that it's okay to have a mental illness, that it's like other illnesses, and that it can be treated, and that people can live lives the same as the rest of us. So I think that would be my feeling on it.
Yeah, it's interesting actually, I suppose, and it's something I hadn't thought of, that it's the serious element of it. Probably does, you know, the stigma thing is there. I suppose when I think of mental illness, it's kind of not your everyday, but I suppose the lower yes. form of it. So yes. It's interesting your facts that that it is, you know, there is still a lot of stigma with serious. Yeah. And just about the educational system, have you any ideas of? Yeah, thanks, Doctor.
So firstly, just an answer to your question about whether we meet with Minister Daly, we do, and we have a request into Minister Daly at the moment to meet particularly on the findings of the My Voice Matters surveys, which are, you know, really give a national picture of people's experience of mental health services. So we're awaiting a date from him in that regard. I'll ask my colleague Kate Mitchell to answer the question with regard to stigma in schools.
Yes, thank you for your question, Deputy Murphy. In terms of the broader question around stigma, I think there are some fantastic initiatives that are happening at national and local levels. This month in May, we have the Green Ribbon Sea Change campaign, which has done fantastic work in terms of raising awareness of mental health and promoting positive attitudes to mental health. But certainly there's research that shows that attitudes towards severe mental health difficulties are still very much lagging behind, and we can see that through research carried out by the National Disability Authority quite recently, that people, members of the public, aren't as comfortable working with or living beside people with mental health difficulties in comparison to individuals in other disability groups. So I think we still have a way to go in terms of challenging attitudes towards those more severe mental health difficulties. And I think some of the measures that need to be taken are, you know, better supporting employers in terms of recruiting and retaining people with mental health difficulties, and for local authorities and placing individuals in secure housing and so on. In terms of mental health in education, similarly there has been some wonderful work carried out by certain schools, teachers, principals, in terms of promoting students' mental health and ensuring that their mental health needs are addressed. But we need to see this happening at a national level and through national protocols and processes. We had national guidelines produced for both primary and post-primary schools in 2013 and 2015 on promoting mental health and well-being, but there has been concerns around lack of implementation of those and lack of resourcing and training for teachers and so on. So I think the key point is that schools really do need to be adequately resourced and trained and supported to push that forward.
Okay, thank you, Ms. McShane. And just a few specific... Sorry.
My colleague here, Rosemary Smith, will answer the question.
To respond to your second question in relation to meetings with the Minister, the Commission, as in the Board, and the Chief Executive would at least meet on at least an annual basis with the Minister, and we meet on a quarterly basis with the officials from the Department, the Mental Health Division in the Department. At our last meeting with the Minister, as all of those matters we addressed that we've raised today, and I suppose in relation to the resource issue, he advised his commitments is in relation to looking at the staffing, putting in the assistant psychology posts within primary care, looking for consultant psychiatrists, because they're at the moment finding it difficult to fill those posts. These were his priorities from that perspective. We also raised the governance issue with him, and it would have been prior, I suppose, to the appointment of the new DG. We spoke about the structures, and like Dr McDade said, we have advocated for National Director of Mental Health and the national offices to be put back in position. We found that unit and the National Director to be very helpful in relation to the governance and accountability perspective, and the lack of that office now, we see that is not as effective around the country. We've addressed that with him at the last meeting, and he's advised to us that he would allow the new Director General to be in post, to find his feet in effect, and then the discussions would take place in relation to that.
Okay, thank you.
The legislation, again, as Dr McDade said, we're expecting that in June, and we welcome it very much. Just, I suppose, that we have had 2 legislative changes in recent times, which have to be welcome. The removal of unwilling in relation to treatment of people who are detained, that they are no longer forced treatment against their will. So we welcome that very much from a safeguarding and human rights perspective. And also the most recent legislative change, the removal of the 12-month orders, that people can be no longer detained for that duration. And finally, Vision for Change. We table that at all our meetings and our meeting with the Minister, and we have looked to be consulted in relation to the policy, the refresh of it, and we look forward to receiving a draft of that.
Thank you. And just a few specific questions, please. Dr Finnerty, you were saying a young person in need of mental health services in Galway, etc., and you know there's different areas mentioned. Why is there such disparity? How can that happen?
It's interesting. In Galway, actually has the highest funding. That's the €92 per capita, whereas areas such as CHO5 have the least funding.
Okay, so it's all down to.
Yes, it is. I mean, the teams have to be filled, and
Yeah. And you also said that people with severe mental illness will die on average 15 to 20 years earlier than other people, and so unrelated to mental health illness, the reasons for their death. Can you just...
The reasons for their death is they're mostly cardiac problems. So the monitoring is really important, because you can prevent somebody from actually developing cardiac problems. So by monitoring things like waist circumference or BMI or bloods and so on, you can actually stop the development of cardiac problems, and you can get in early. Okay. And it's the difference between treating somebody very proactively rather than somebody ending up in ICU
and treating them then.
Yeah.
Okay. Mm-hmm. Okay. Yeah, so it's the whole issue of CAMS. It's we have a lot of people coming into our office trying to access that service, and it would be great if something could be done that that it's just very easy to access, and again to stress the importance of the 24/7 access. I suppose mental illness doesn't hit people just in office hours. So it would be really good if we could get a date from the Minister, you know, when all that will kick off. So thank you, ladies. Thank you, Chair.
Thank you, Deputy Murphy. And now Deputy Louise O'Reilly.
Thanks very much, Chair, and thank you to all of our witnesses for coming in this morning. And I join with my colleague in saying it is a very refreshing and welcome change to have an all-female panel, and to the people who will be jumping onto Twitter now to give out that I'm saying that they better do so, and preface it by showing themselves giving out whenever there's been an all-male panel, because I know people don't, but anyway, it is very well, and you are all very welcome. Reference is made in the mental health reform submission to the piloting of mental health supports. Now, I'm aware that in Britain they're using a crisis text line. I think it's called Shout. It comes from an American-based model, as I understand it, but I have concerns about e-health in general. I'm not convinced of the merits, but I have very, very particular concerns in relation to mental health and mental health supports, and I just would be interested in your view, specifically in you know, where you see I suppose as a backup mental health, when there are a range of other services, mental health being a small part of it, not so much of an issue, but abandoning traditional services in favour of online supports. You know, I mean, if you give someone an app, that's not the same as offering someone real support. That's not going to where the person is at. That's simply fending off a problem and not actually getting in and dealing with it. So I just would be, as an opener, I'd be very interested in your views. Thank you.
Thank you, Deputy. Yeah.
Dr. McDade.
So yes, and mental health reform has been looking at the area of mental health or digital mental health over the last few years, as we're the Irish partner for a across Northwestern Europe project to explore this. And one of the reasons that mental health reform wanted to be in that role was that we see that we are in a position to open up the discussion about digital mental health, explore the pros and cons, and facilitate knowledge sharing, and so that people in Ireland and the professions, as well as service users and service providers, can be fully informed on this basis for figuring out what that role should be. I suppose what we're seeing in the evidence is that it's effective, particularly in a blended therapy approach. And what we mean by that is that the digital mental health support is a complement to the support that's provided by a mental health professional. And so particularly in primary care, you could think of the digital mental health support as being bookended by an initial consultation with a mental health professional, and then follow up with a mental health professional. But in between that time, the online program, particularly online CBT, seems to be getting pretty good evidence as something that people can do. And that the mental health professional is always informed of how they're getting on in that program as well, so that the information is available so that the mental health professional can see the progress. Now, what does it do? Well, first of all, it makes the mental health support much more accessible to people wherever they are. And this is a significant issue. For instance, I've heard of situations where, say, mothers with young children find it very helpful to be able to access a mental health professional online, because it's very difficult for them to actually get organized and have the opportunity to go into an appointment on their own. For people where their stigma is an issue, that digital mental health can help them to access support where they don't have to go onto the high street into a clinic that says mental health on the storefront. So we do think that there's potential there, but we're really interested in exploring that and seeing how to make sure that it's done in a safe way, in a good practice way. And that's why we, for instance, did a seminar jointly with the Psychological Society of Ireland last year to make sure that we're all learning about the appropriate way to bring digital mental health into the system.
Yeah, so the difficulty I have, Dr. McDade, is not that there may not be a place for it in a functioning mental health system, but we have a dysfunctional mental health system, and the supports don't exist at the moment. So my worry is, and this is something that I have not a particular interest in, but I have recently taken an interest in. My worry is that this is a cheap way of offering support. And it is. I mean, it's obviously always going to be less labour intensive and all of that. But I mean, you said that a person may not want to walk down the high street and walk into the shop front that says, you know, mental health supports. They're not there. So that option is not there for people. It's not that people are saying there's a whole range of supports available to me and I wish to choose the one that's online. My fear is that people are saying there is literally nothing. I want to talk face to face with a person. I want to be the one that walks down the street and goes through that door. I am actively seeking help, but all that I am getting is an app. And where the point that you make is very relevant, where it is bookended by professionals and where that is available. But my fear, you know, and my understanding is that these crisis helplines don't necessarily, or crisis text lines, don't necessarily deliver the type of support. And I think that as the studies go on, there will be evidence there that they are, as a complement to services, not necessarily a bad idea. But as the service themselves, they are going to be wholly inadequate, and in a space whereby we have difficulty recruiting and retaining staff, this becomes nearly an outsourced way of doing it, and that's where my fears would lie.
Yeah, and as I've said, I don't think it should become a substitute for mental health professional care. I think we have to look at what people who might need that help, whether they're what we would call mental health service users or people who with low-level mental distress, you know, who are looking for an early intervention. We have to look at what they want and their preferred options. And many people will still want to see someone face-to-face, but some people will feel more comfortable with a digital or online option. And I think it's about creating that choice for people.
Thank you.
The Commission would welcome telemedicine and have done so, advise the Minister, but in the context that it's not filling a gap, that the appropriate resources are there to refer people on, and that the services need still to be enhanced. As, it's not to fill a particular piece without having the full support structures in place. And secondly, I suppose most importantly, that those that are providing the service are regulated either from an oversight body like ourselves or a professional regulator, that there's governance and oversight of such a service.
But would it make sense in your opinion that these services should be put to one side for the moment in favour of developing the more traditional? We say telemedicine is quite a new thing, and I have to say, but cards on the table, I don't like it. So I have a personal opinion about it. It's not something I would like either to see a doctor or a mental health professional or anyway. But that's a personal thing. But in the absence of services being developed, I think it would be, I would caution against going down the road of telemedicine, because every person that's spoken has said it's okay and it might be positive as a complement to existing services. The difficulty I have is if we go down that road before we build up the other services, then it becomes ever increasingly less likely that we will develop the other services, and we will simply have the idea that was intended to be the complement to the services becomes the only service. And I would caution against that I would say maybe you just park that for the moment and then focus solely on the development of the services that are so lacking. I mean, I live in North County Dublin. You know, the waiting times to access a person face to face for kids running up to 30 months. You know, and I would be nervous that families who are families in crisis and getting further into crisis, according as the wait goes on, that they would simply be offered an app or some version of telemedicine without the additional supports. And then, because all of the staff are under pressure, the box is ticked, supports are there in place. And that's, I just think that maybe there's a space for the service, the telemedicine service or the e-mental health support to complement existing services. But in the absence of existing services, I don't believe that telemedicine model will work or be effective, because it's not intended to be the service, it's intended to be the complement to the service. And indeed, Dr. McDade, you make a very good point that, you know, people should, those mental health service users should be asked, they should be consulted, their opinion should be sought, the service that they want and that they need should be delivered for them. But the fear I would have would be that the service will be developed because it is cost efficient, it's much cheaper than another version of it, and that's where the focus will go, and the focus will go off making up the deficit.
Yeah, I mean, if I was to respond to, Deputy, to your comment, I would just say I can't see it as an either or. I don't think, you know, for instance, I think we have an estimate that there are 300,000 adults in Ireland over the course of a year who have a mental health difficulty of some level. And our counselling and primary care service has capacity to see 11,000, less than 10%, right? So we need both, and we actually need both urgently, you know. So I do think that we need to build up the support, the digital mental health supports and the options for using that throughout the mental health system, but that we need to do it safely, and we need to do it in a way that recognizes the integral and vital role of mental health professionals in our mental health system.
Absolutely, thank you. And Chair, if I could, I have one very brief question. It relates to attendance at accident and emergency. I know, because I have people in my own constituency who have come to my office because they have had to bring a loved one to accident and emergency. The person does not have a physical ailment, but they have literally nowhere else to go. So the only door that is open to them is the accident and emergency door. It is the absolute last place they want to be. And I'm wondering if you could maybe just talk for a moment or two about the impact that has. As a former trade union official, I represented nurses and a lot of A&E and emergency department nurses. I know the impact that it has on staff, people who want to do their best but don't have the training maybe to, you know, to be able to cope with a person who is in experiencing mental health distress, finds himself in accident and emergency. But you might just advise or describe for us what the impact on the individual themselves, because I know the impact on staff is absolutely horrendous, but you might be able to describe what the impact on a person and what happens to them after they present at A&E, which, as I think we all agree, is the absolute last place they want to be, the last place they should be, but the only place in some instances where they find an open door.
Yeah, thank you, Deputy O'Reilly. I think you raised a really important question, and mental health reform has been carrying out consultations in different parts of the country for a number of years, and it's one issue that we have heard consistently from people who use the services of self-experiencing mental health difficulties, from family members, but also from mental health professionals that really echo what you're saying, that when somebody is in mental distress, they're in crisis, A&E is the absolute last place that they want to be. It's not an appropriate environment. It can be quite distressing, it can be very noisy, it can be very loud, very chaotic. In a lot of situations, they're waiting extremely long periods of time to be seen by a mental health professional, and in some cases people will actually leave before they get the support they need, which can lead to tragic consequences. Mental health reform has been advocating for out-of-hours mental health services. We have had a commitment from the Minister for Mental Health to roll out 7-day-a-week services in all parts of the country for adult adult mental health services. About 36 of the 48 posts required to deliver on that rollout have been, the recruitment for those 36 has been completed, with an additional 8 posts accepted. But that implementation of 7/7 is slow, so it's important that we see implementation of that as a matter of priority. But also for children, that there are many areas of the country where there are no 7/7 or 24/7 mental health services, and children and young people similarly have to go to A&E when they're in mental distress and crisis. And often when they go to A&E, don't get to see a child and adolescent mental health professional. They're seeing adult consulting psychiatrists, with many families and children having to wait quite considerable amount of times to get that crisis support. So we would similarly say that there needs to be rollout of 24/7 services for children and young people, and really important that that's implemented as a matter of priority. Thank you.
Harty?
Yes, I do agree. After hours in nearly all places, really, it's the A&E that people arrive at. There are some services that do provide an 8 to 8 or a 7 to 7 service, and there are a few that provide a limited 7-day service, but it is very, very limited. And the other, I suppose, difficulty in some places is that when people do come to A&E and are seen by the psychiatrists, that the beds, the units that they would be admitted to are full. So that leads to all kinds of difficulties, people staying long lengths in A&E, people being discharged maybe from A&E when it may not be the best thing for them. During office hours, there are in most cases day hospitals or areas where people can actually come and see somebody in an emergency situation, that they don't actually have to go to A&E. And in some places as well, not everywhere, there are home-based treatment teams that will actually go out and assess somebody in their home. But it's very patchy and very inconsistent across the country.
It is, and I mean, in a scenario where you can schedule, you know, the appointments and stuff, and only hit that crisis between 9 and 5. Even at that, you're still not guaranteed you'll get the service that you need. Yeah. But the reality is, you can't. This is unscheduled care, no matter what way you look at it. You know, and it can't. Having a service there 9 to 5 is no use to you at midnight, you know, and it is, I think, for not just for the patients themselves or for the person themselves, also for the staff who can't do nothing for them. I think it's very regrettable. It is something that will have to be worked on. Thank you, Chair.
Thank you, Deputy O'Reilly. And now Senator Colm Burke, or Deputy Durkan.
I defer to my colleague from Munster.
More senior person.
Thank you, Chairman. I welcome our witnesses this morning and thank them for their reports. Can I ask, in relation to the variation in terms of spending across the CAMs, and particularly the 40 to 92 per capita variation, is that caused by a local need? Is it caused by investment in outdated services or structures? Or what's the main cause of that? There's a huge difference, more than double, and it needs to be addressed, because if that's a symptom of what's right across the board, it's a serious problem.
It's difficult to know exactly what's causing it. The service in Galway is a particularly proactive service, and have developed a number of, I suppose, good practice initiatives such as advocacy. They have an emergency bed, they have other beds in that region, and they have developed the services very well. That in itself attracts people to come and work in that service. I think CHO5 find it particularly difficult because they can't actually get staff to work in that area, and that in itself down the line decreases the chances of getting people to come and work, either allied health professionals or consultant psychiatrists. The service in Galway, again, it's a very established service going back many years and has attracted, I suppose, funding in order to maintain that, and whereas the CHO5 area would be a newer service, they don't have beds in that particular area, and in fact find it very difficult to get inpatient beds for CAMs. So I think there's a number of factors in it.
To what extent has any review been done with a view to addressing that imbalance? For example, I have an idea as to why staff can't be found to work in Area 5, but I'd like to hear it more graphically. If there are issues that lead to patches in the system, should be no patches in the system at all, should be equal across the board. And we need to know, Mr. Chairman, what the cause or causes are, and if there are particular specific causes, which I think we know, then we have to address them. Yeah. Can we do that?
I suppose the reasons for that would rest with the HSE. We don't actually have any, we don't fund the services ourselves, the Mental Health Commission doesn't do that. I mean, the decisions of how to fund the services and to provide the services belong to the HSE.
But sure, when there's a huge imbalance like that, to whom do we apply? And I'm not asking you to make a comment or criticise the HSE, far be it from that now. I would be the last to do that, Mr. Chairman, as you do well know. As you do well know. But we need to know precisely and starkly what the issues are, graphically.
I think the provision of services is a matter, I suppose, for the commissioners, which is the HSE in this case, is, for the child and adolescent beds. The Commission conducted a review going back a considerable number of years ago now at this stage, and I suppose what the result of that review is that it indicates there are enough inpatient beds within our jurisdiction for CAMs. The problem lies within the community services, the teams within the community service, in order to prevent, I suppose, people warranting admission, that that care and treatment isn't available prior to somebody warranted admission. And we talked about waiting lists and waiting times. It comes to a point in time then people needed an admission. The structure of them, I suppose, that was a decision by the commissioners where to locate the CAMS units. So they're located in Galway, Cork and Dublin, the three, and one in Vincent's and Fairview. That was decided by the commissioners. Also the age groups that they take in, that there's only 3 of those 4 that's provided by the state that take in over 16 or under 16 years of age. So again, we're reducing the number and the capacity down, and again that was a decision by the commissioners in relation to the age group that would be admitted to these units. And in the lack of that provision, and which the Commission has repeatedly, I suppose, requested that the provision of 24/7 out of hours and community services be developed.
So, Mr. Chairman, are we to assume that the various regions have a huge amount of autonomy in the degree to which they develop the service or fail to develop the service? And what's been done, or what do you recommend to address that issue? Again, Mr. Chairman, I emphasise there should be no patches in the system that are not capable of delivering and dealing with the issues.
We would recommend, obviously, that there's equitable access for everybody within Ireland to adequate CAMS services, and that the funding is equitable across, so that it's not a postcode provision of service, so that somebody, as I pointed out, in Galway gets a better service than somebody that is in Waterford or other areas. So we'd certainly recommend that there would be equity in funding, and that there would be equitable access to the services.
I just point out again how the importance of having a national director who has authority over the budget across the entire mental health service and the role that that plays, keeping in mind that we only had a national director for mental health from July of 2014 until 2018, so a relatively short time in which there was an office holder within the HSE who could require and look at spending across the whole country and then make decisions in terms of prioritizing spending, based on need, based on deprivation levels in certain areas, and trying to rectify historical and legacy imbalances.
Is that happening?
Well, it's less likely to happen now because we no longer have a national director, and so now the decision-making around the budget is more devolved to, and is moving in the direction of being more devolved to the regions. And that's the concern with the new structures in the HSE. So
the HSE is the overall coordinator as to where the money is being spent, on the basis of which it is being spent, and presumably on the basis of a good investment to improve the services and address the issues insofar as patients are concerned.
Well, it is ultimately the account holder, and it should be responsible on a national basis, but our concern is that the structures that are in place now don't really facilitate that very well, because there isn't the same level of accountability that there would have been when there was a national director for mental health who was responsible for the mental health budget.
So you're saying that that's an urgent need to have?
Yes.
Yeah. All right. Can I mention then, just I saw reports some years ago of the number of children between 10 and 13 admitted to A&E having self-harmed or whatever, had a mental breakdown. And some of the same children admitted more than once, and some of the same children, obviously, tragically having a tragic ending. So can I ask, to what degree does the system, as it is now, interact with those children, identify them, and try to protect them and provide the kind of services that they require? They may be in a difficult home situation, there may be addiction situations involved, there may be a variety of reasons contributing to their particular situation and detrimentally. And in those circumstances, what do you see as being the most immediate and urgent intervention in order to address the issues?
I'll ask my colleague Kate to answer that.
Thank you for your question, Deputy, and absolutely that it's a fundamental issue, and I believe the figures on self-harm, on presentations of self-harm, continue to be significantly high among our younger population. There has been a clinical care programme, a HSE National Clinical Care Programme, that was introduced on self-harm presentations to emergency departments, and that has been in operation since 2014, and I believe has been expanding to each of the emergency departments across the country. So my understanding is that there are 24 emergency departments that now have a dedicated self-harm specialised clinical nurse in post, with the aim of expanding that to three paediatric hospitals. So as far as I'm aware, that issue is being addressed, certainly to some extent, through the Self-Harm National Clinical Care Programme, but it would be very important to continue to review that programme, to monitor it and to ensure that it's being implemented effectively.
Is that being done?
There was a recent review of the Self-Harm Clinical Programme, certainly, and there was mixed, I believe, mixed reviews in terms of how it was operating in the different hospitals. So it will be important going forward that there is consistency and standardisation in terms of how that's rolled out across the country and how it's been implemented in different hospitals across the country. But I think there are certainly other measures that need to be put in place. It's not the full solution. So, for example, there's a requirement, for more out-of-hours services and crisis services for children and young people to support that need.
Dr. Finnerty, sorry.
Yes, just the age range that you gave, Deputy, 10 to 13, if a child is coming into an A&E at that age with self-harm or suicidal ideas, that certainly needs a response from the Child and Adolescent Mental Health Services. And I think the difficulty is, as we have both said, that isn't available in every area. So that is obviously concerning, and that we would recommend that there would be out-of-hours service available to A&E, so that in CAM, so that children that would present, especially at that age, would be picked up by the CAM.
But before the situation reaches A&E, Mr. Chairman, I would be interested to know the degree of interaction, either through the schools or through the GPs or whatever, by whatever system, whereby those children and their families, or their families in general, can have access to the required level and quality of service to address their specific issues. To what extent do we have that in place? Because I have, from dealings, and I'm sure everybody else here as well with similar dealings, can point out to cases where that didn't take place, where there was a void, and as a result there were tragic consequences. And the point I want to emphasise, Mr. Chairman, is to what extent does the psychiatric, child and adolescent health services identify the children through the schools and deal with it and offer the support and reassurance and whatever is required. I have two other questions, Chairman, and I finish then.
I mean, I'll just make one comment about that, really, in reply to your question, which is where you have services like the CAM services are clearly very under-resourced. They have about 56% of the staff that are recommended at the moment, very under-resourced. Inevitably, those services then retrench. In other words, they heighten the criteria for getting in because they feel that they can't cope. And we also have this huge increase in demand. I think it's about 25% increase in the demand for child and adolescent mental health services in
between 2012 and 2016.
Between 2012 and 2016. So you have a kind of a perfect storm there. You have an increase in need, you have inadequate resourcing, and therefore, in the face of that, what are staff going to do? They're going to increase the threshold that people can get access to mental health services. So ironically enough, it may be harder now for CAMs to do the kind of outreach in schools that they should be doing and that the interaction they should be doing than it might have been, 10 years ago. So, so you're absolutely correct that is what should be happening. In other words, schools should find it relatively easy to, if they have a concern about a child, to be able to contact the Child and Adolescent Mental Health Service and get the advice and support and guidance on should this child be referred in. And we don't get a sense that that's routinely available across the country. And I'm just pointing out why that might be the case. So it's not enough to simply just blame the CAM services and say they should be more open. There also has to be adequate mental health support throughout the system. That means within the school, in primary care, and in child and adolescent mental health services.
Thank you, Dr.
Chairman, there's obviously a huge difference in the degree to which funding is available in some areas. Obviously, the one that has double the funding relative to an area under pressure, there's obviously a gap in the system there. And, I know there's information available, and I'd like it to be made available to the committee. The areas that are underfunded in terms of child and mental health services, could we have a sort of progress report on the extent to which the services are either meeting or failing to meet or unable to meet for whatever reason, in comparison with those who have a different funding chain?
Yes, I think that would be a very welcome thing to ask for from the HSE. And bearing in mind that the HSE used to publish an annual report of the Child and Adolescent Mental Health Services, which they are no longer producing on an annual basis, as far as I'm aware. So it would be very welcome for the committee to request that the HSE get back into the practice of publishing that annual report on child and adolescent mental health.
Two last questions, Chairman. One is in relation to medication, and particularly with children and adolescents. The mother in particular can have a concern about restraints and the extent to which the child, as growing older, is either doesn't take the medication or isn't supervised to the extent that they should in taking medication, or progression of their particular condition may be a contributory factor. How do we reassure the parent in these situations that their child is safe when they go to receive treatment, or whether they're in respite or whatever the case may be? I think there's an area there that we need to reassure the parents in order that the state is seen as a helping, supportive and fair instrument in dealing with their child's particular condition. And the last one is in relation to housing, Chairman. And again, we've all come across this, where young adults and adults, in fact, in particular situations, may have been sleeping rough or whatever the case would be, finally referred to what used to be called sheltered housing, no longer sheltered to the extent that I think it should be. But the need to try to ensure that the patient is in an environment, that the person is in an environment that is supportive, that doesn't undermine their self-confidence and their self-esteem, and that they can feel themselves and their families can feel that they can rely on that for the best possible treatment of their relative.
Yeah, I'll answer the second one first, if I may, Deputy, about the housing. Yes, we would have concerns, as I mentioned in my submission, about the residences that are supervised over 24 hours. We would like to see them that they would respect the autonomy and the dignity of the people that are residing in them, both through how they treat the resident, but also the environment in which they live. As I said, in 19% of those currently, the environment is unsatisfactory, and something needs to be done urgently about that. And also the fact that they're also very large, so that the tendencies for people there to become institutionalised, to lose their independence, and not be part of the community. And that is why the Commission is very anxious that these residences would be regulated. While I can inspect them, we can't enforce action because the Mental Health Act does not allow us to do so. So again, we recommend that they would be regulated, and that would help us to ensure that these residential places are suitable for people, either young or elderly people. Your second question, or your first question rather, on medication. It's very difficult to reassure somebody about medication and the effect that it has on somebody, or how the illness is going to progress, if you don't actually know the circumstances of that particular person. And I suppose the clinical team are really best placed to do that, and to make that possible. But I would say that in cases like this, that every effort should be made for people to communicate with the treating team, and that the family and the young person involved are involved in their treatment.
Thank you very much, Dr. Finnerty. Now we're going to move to Senator Colm Burke.
Yeah, thank you very much for your presentations here this morning. And I think it's important as well that we acknowledge the work done by everyone who's working in the mental health service, because it is a very demanding area, and I think it's important that we acknowledge the work and the dedication and commitment by all of the workers in the mental health service. There are just a few issues that I have, and I know you touched on some of them already. The first one is in relation to CAMS, and I suppose it's my own experience of having to deal with issues where parents have come to me, especially in relation to medical practitioners who are dealing with adolescent mental health. And what I'm really concerned about, I had an area where there was no medical consultant available in the area. And if he was a half mile up the road, he would have access to a consultant within a very short period of time. And I don't understand the geographical boundaries that are being identified in relation to who the person sees. In other words, so if you're in the wrong area at the wrong time where there's no consultant, then you might have to wait anything up to 18 months to get to see someone. And I've had to deal with that situation where I had a 16-year-old where the parents literally had to monitor their son non-stop for that 18 months and CAMS wouldn't get involved until the person was assessed. I don't understand, if you don't have a consultant, why there isn't some other process in place to make sure it's dealt with. And for instance, they ended up taking the person to accident emergency. Accident emergency then sent the person back home without any real without any additional care plan in place. And I think that's something that needs to be dealt with. Why are there geographical boundaries? For instance, you're taking maternity services. We don't have that kind of geographical boundaries in relation to maternity services. Why do we have it in relation to adolescent mental health? That's one issue. The second issue that I have is in relation to a growing challenge that we will now have to deal with in relation to people who are non-Irish, who have come to Ireland. They don't have the kind of family support that your traditional family would have here in Ireland. And I had a case recently, for instance, where a girl was in Ireland for about 12 years, non-Irish, no family in Ireland, and she was in rented accommodation and was in serious difficulty mentally. The landlord went to her GP for the GP to come down to see her because she wouldn't go to the GP herself. GP's response was, contact myself as the public representative for covering the area. That was the response to GP. 4 weeks later, still nothing else. I got on to the public health nurse. Public health nurse's response was, I can't call there unless I'm requested to call there by the GP or by somewhere up along the HSE. So I had 4 weeks where there was no action taken. Eventually, the landlord took a recording of the person because the person was really, really going downhill very fast, went to the GP, and only after playing back the recording to the GP did the GP come to see that person. Now, the challenges that we have in this case is that the person was admitted to psychiatric services for 8 weeks. They're now back out in the community again, back into the same residential accommodation. And the landlord is now on to me saying, look, this person has to leave by the 30th of June. And I don't have a backup support service there now. And I'm just wondering, how are we now? Because this is just, I'd say, one of many problems where we have a lot of non-Irish people who, unfortunately, will end up in this situation where they don't have a fallback situation in relation to family. And we will end up with people like this on the street. And I'm just wondering, what do we need to deal with forward plan on this issue? The third issue I have is in relation to the cost, in relation to how you balance that. I had a case where a person in their mid-30s, and in fairness to HSE, were doing their best, but the HSE could not have applied. They had to apply 2 care assistants every time to the person because a care assistant on their own had been assaulted. And a package was done up to provide care for this person out in the community. The cost of that package was 130,000 per annum. And, there must be a way of dealing with a situation like this where the person has good days and bad days, but the assessment is that the person should be out in the community as opposed to being in a more, I suppose, definitive care situation. And the fourth thing I want to just raise is this, the lack of information out there. I have another case where I have a guy who I know for a long number of years, and I've been talking to his family recently because, in fact, I've been receiving something like 10 or 20 emails a day from this person, and they're now in the under the care of mental health services. And having spoken to their family, who've now totally distanced themselves from this person because the person has caused a lot of difficulties for the family, and the family are quite convinced that it was the use of illegal drugs over a long period of time has now caused this long-term problem of mental health problems. So I'm just wondering, you know, we're not getting information out there that the use of illegal drugs can lead to mental health issues. And I don't think there's enough information out there for young people in particular, where, and I've come across a number of cases now where people were perfectly well health-wise, got into drugs and have now long-term mental health problems, and there is no road back. And I'm just wondering how you would propose dealing with that issue. Do we need to do a lot more information out there, and where do we start with that whole process?
Thank you, Senator.
Yeah, just addressing your first question first, where there's no medical consultant, no CAMHS consultant in a certain area, and 10 miles down the road there is one. There have been some difficulties over the past few years in filling posts for CAMHS consultants, and there have been occasions when in certain areas there hasn't been a consultant available to actually provide a service, and sometimes they will cross over from another area or another CHO to try and pick up any of the emergency cases. And certainly I know that again, CHO 5 ran into some difficulties with that, and the services from other areas came down and went through the waiting list and saw the urgent cases and so on, which is not ideal at all. The difficulty there was actually in recruiting consultant psychiatrists. The posts were actually approved. The second question was, in fact, maybe Sherry might like to answer about the non-Irish, because you've done some work on that.
Yes, well, I mean, I think the point there around forward planning is very well made, Senator, in that we've been calling for some time now that the mental health services need to develop a whole program of cultural competency for staff and developing a culturally sensitive service, so that all the mental health services across the country, and of course this is going to have to apply to mental health care delivered in primary care as well, you know, are equipped to support people from different ethnic communities, new communities coming into Ireland. And that extends as well, not just to developing a level of staffing competency in providing services to people from diverse cultural backgrounds, but also to planning for services that have adequate capacity to support individuals in distress, you know, in those circumstances. And I think that's really where your story hints at a failure to adequately plan for a new situation in Ireland, which is that we have a more diverse community. So I would welcome that being a priority within the HSE, for them to plan for services that can provide support for people from ethnic minority communities coming into the country. And they will probably need to do that in partnership with other services around the country. For instance, the direct provision system. You know, there needs to be a communication and collaboration there between those organising direct provision and the mental health services as well.
The third question about the cost package, how expensive that is, and how it should be based on need. I think, Senator, is what you were saying. There are a number of people who have very complex psychiatric needs, and they do require very expensive packages to care for them. And what's happening at the moment is that they're either treated out of this jurisdiction, or otherwise they are the care is provided by a private company with the HCAs or the mental health nurses providing a care for them. And it is expensive, but there is no facility at the moment in Ireland where people who have such complex needs and such high staffing requirements can actually be treated.
No, but the point I'm making is that the point put to me was this person is out in the community, and the argument being put to me is that they were seriously questioning whether in fact that was the right decision, and to keep them in the community, the cost was so high that if you go back to a number of years ago, that person would have been kept for a substantial period of time in more permanent care, and that seems to have totally changed. Where the argument put to me was that this person wasn't suitable to be out in the community because members of the person's own family had suffered injury as a result of being assaulted, as had care workers as well, and that there was a serious issue about was this the right decision? And that seems to be happening where there is a total reluctance about keeping the person in more clearly defined care, and instead referring it out in the community where the supports aren't necessarily there, or if they are there, the difficulty in getting staffing and the cost of that staffing is extremely high. Just coming back to the CAMS issue and the geographical divide, I still don't accept that because there's a boundary half mile up the road from a person's house, that they have to wait ad infinitum. And the other question is the definition of urgent care. If you have a 16-year-old who is borderline as regards, self-harming or whatever, I think that's urgent care. And yet the system seemed to say, sorry, to the parents, you have to go on a waiting list until you see the consultant. Then CAMS can't get involved until there's a full assessment done. I think something has to change on that, and that geographical boundary shouldn't apply, where, in other words, that if there's one consultant not available, then that there should be some process set up immediately to make sure that no one is left in a limbo situation, which this family were. And I had a number of other families in the same area who were caught in the same dilemma. And for quite a long period of time, there was no assistance being offered. And that has to be dealt with.
Yes, no, I do agree, and anybody that needs urgent care should be assessed by a consultant psychiatrist or the CAMS teams. The geographical areas, the HSE have divided the country into certain geographical areas, CHOs, and then within that into various sectors. I'm not sure how strong the boundaries are between each team or each CHO, but certainly we would say that anybody that needs urgent treatment, urgent interventions should be seen and not told that they can't be seen because they live in a certain area. That would not be.
But if we applied the rules that are applying to the maternity services, we'd be in a right mess.
Yeah.
And we seem to be accepted in the mental health services. It doesn't make sense to me.
Can I just come in briefly? I think the issue you're raising really highlights the gaps in terms of staffing in the mental health services. So where there isn't a consultant psychiatrist available in one area, there may be a consultant psychiatrist available, a mile down the road or a couple of miles down the road, but there there is a list, and a waiting list for that particular catchment area also, and I think it really does highlight the need for enhanced efforts to recruit the consultant psychiatrists required, but also to focus on recruitment of allied health and social care professionals. Also, that we really need to see an increase in the number of psychologists and social workers and occupational therapists and so on, so that children and young people and families can get access to the services that when they require them.
Yeah, but the argument now being put in this particular case was that CAMS cannot get involved until there's a full assessment done by a consultant. Surely, where there isn't a consultant in place, some intermediate action should be put in place.
So under the current legislation, under our current Mental Health Act 2001, the consultant psychiatrist is defined as the clinical lead for that service. So under that legislation, that requires for a consultant psychiatrist to be in post to make that assessment. So that is set out in legislation, it's set out in policy. So if the committee is to look at that issue, we really need to look at it in the context of existing legislation. There are other jurisdictions, for example, in the UK, where a clinic or a consultant psychiatrist isn't required to make that assessment and takes on the role as clinical lead, but that's not currently the case in Ireland.
But see, the problem in this case is that there is consultant psychiatrists in this area, but they're not dealing with adolescent mental health. And this is the argument I have. No one is taking responsibility. The question arises is who is now in charge in that area once an adolescent mental health consultant is not available? Who's in charge of that area now? Like, who takes responsibility when that arises? Because there are mental health consultants in the area covering this geographical area but not covering adolescent mental health. And I think there's a bit of buck passing going on here where no one is taking responsibility even though the person is living in the area.
I think that would bring us back to the point both ourselves and mental health reform raised in relation to the governance of the services and accountability, that is something that we can't see is actually happening, and we would very much welcome that to be addressed, to rule out situations and examples like you're giving us here today that they don't occur, and somebody is held to account for that person's care, the child's care and treatment, the example you gave to us, and that doesn't exist. That's what we're finding at the moment, that does not exist. And just to pick up on a point by Kate that she raised about the legislation, the legislation only pertains to children who require involuntary admission that has to be assessed by a consultant psychiatrist, and that is a very, very small proportion of children who are admitted under Section 25 of the Act. So, we would be advocating that an assessment should take place by any member of the team when they present at A&E or wherever they present, that an assessment should be made of an individual, and if, as Dr. Finnerty said, urgent, it's seen as an urgent need, then it should be addressed by a consultant.
Okay. Just on the drugs issue and the connection between mental health problems over the abuse of drugs, I'm just wondering if you could touch on that.
Certainly there's been concerns for a long time about the silo between addiction services and the silo of mental health services. The wider point that you've made, and I think it's helpful that you've brought it up, is that the evidence is showing itself more and more that certain illegal drugs are actually seem to have an association then with severe mental health difficulties arising, particularly I think psychosis, where there seems to be a link for certain drugs. And that message does need to get out, because one of the things that we're not focusing on enough at all in Ireland is the prevention of mental health difficulties arising. And we'll never be able to cope with the demand if we don't actually put more of our effort into prevention and into educating people about how they can be involved in preventing their own mental health difficulties and the mental health difficulties of their family members, of children, So, I think that's a point well made. But one of the challenges is that where that does arise, where someone has a history of addiction or of misuse of illegal substances, and a mental health difficulty presentation, that too often in our system they are turned away from one or the other service, being told, well, no, you have to sort out your issue with regard to your addiction first before we'll see you in the mental health services, or vice versa. Probably more often it's that they end up in addiction services and they really need mental health supports, and the mental health supports are not being brought in an integrated way. So I hope that that will be very much addressed in the revision of A Vision for Change. A Vision for Change, I don't think, was very helpful. It seemed to kind of set up a conception of addiction services as being very separate, and of addiction issues being separate, except where very clearly a mental health difficulty was kind of, prior. And I think that I'm really hopeful that the next mental health policy will recognize much more that substance misuse and alcohol misuse are frequently features with someone who has a mental health difficulty, and that they need holistic support.
But do you not accept that? Do you not accept that we need to do an immediate health information on this issue? Because I come across someone recently, for instance, who is in the maternity services. Person is pregnant, and on 3 out of 4 tests, cocaine showed up. That the person was using cocaine, even though they had been warned time and time again that this was going to cause problems for them. And in 3 out of 4 tests, cocaine showed up in the results.
Yes.
So, we're not getting a message out there.
Yeah, I think that the evidence needs to be really put forward for people so that they understand what they're getting into when they're taking those kinds of risks.
Now, Senator Dolan.
And first of all, my apologies to everybody. I wasn't able to be here sooner, and if I touch on something that was dealt with earlier, give me short shrift. Don't go through it again. And I have 2 generic questions for both sets of witnesses. You're all very welcome. One is, can you name 1 or 2 critical issues, areas or services that are outside of the health services that have a significant impact in relation to the people that you're concerned about? The second one is, and Sherry McDade just mentioned it there again, the prevention. We have the analogy of it's better to prevent people falling into the river than to try and be able to pull them all out in time. It's a 2-part question. Is there, in relative terms, are we spending too much effort on trying to save people, and do we not have enough on the keeping people well most of the time? Yeah, and I'm not suggesting that resources being taken from one to the other. And they're my 2 general questions. I have a couple of questions for the Mental Health Commission. I think it was great to see you putting up your executive summary. You have 7 bullets there. The first one, you say there's some good things happening, but you've actually gone, if you like, forensically, but in a sentence, set out 6 areas where there are serious issues. Basic and fundamental aspects of treatment in regulated health services continue to be lacking. Lingering complacency around restrictive practices. Specialist community, and a large number of specialist community health teams remain without regulatory oversight. Lack in terms of rehab supports for people with enduring mental health services. The whole issue of the physical health needs of people with enduring mental health needs, and the provision of child and mental health services in the community. I just want to focus on the second last one there. General health, stroke, disability, other conditions. What's the interaction there, and how might that be dealt with differently? I think maybe the drugs thing was almost a parallel of it in terms of trying to slice and dice people. The other question I wanted to ask you was, you're the Mental Health Commission, you're the regulator of mental health services. And and you're there to protect also the interests of people admitted and detained under the 2001 Act, which is quite a critical thing and long, long overdue. You're therefore, dare I say, locked into people who are in services, or kind of on the cusp of them. We've heard it eloquently set out by Senator Colm Burke. So what frustrations, concerns, issues, I don't want to be leading you, what have you to say about people who are not in services and should be in services? So I'll leave that at that. If I can come to mental health reform, you very nicely set out in your first page 3 major issues: governance, accountability, protracted delays in reform of the 2001 Act, and we hope we don't have to wait as long between the 45 of the 2001 Act to get the next Act and get things moved on, and the implementation of the National Mental Health Policy. But I just want to focus in, given the time, the United Nations Convention on the Rights of Persons with Disabilities. Will you comment as briefly as you can around what that requires and what Ireland has said it's going to do, and where Vision for Changes Act and where the Mental Health Act is or isn't? Yeah. And the final question, on your second page, you say the Irish mental health system suffers from a severe lack of capacity in the face of increased demand, which has pushed the mental health services to breaking point. What do you actually mean by that? When is that going to happen if something doesn't change? Shinna Will Cahirlock. Thanks.
Senator. Dr. Finnerty.
Right. I think with if I may, Senator, address the general health first, if I may, and we did touch on it a little bit earlier. The main, I suppose, point really is that people with a serious mental illness do die 10 to 15 years, or even 20 years before people who don't have a mental illness, a serious mental illness. And in the main, this is due to preventable factors. Preventable.
Oh, it needn't be.
That needn't happen.
Yeah.
And I think that's the point. And the preventable ones are the cardiovascular illnesses, so heart disease and stroke. And it is very easy to monitor this and pick up very early if people are showing signs of physical health problems like that. So in the same way that we go to our GPs for our lipids and weights and so on and so forth, excuse me, people who have serious mental illness and who are on medication need to have the same as well. And we found that in a small group of inpatients, this was not happening. And the other factor that we also found was that the access to essential health care, such as dietetics and physiotherapy, speech and language, were not there either. Whereas they were available, excuse me.
Is it that they're not there, or people aren't connecting with them, or
they're not provided? They're not provided for people. These are inpatients provided for people. Yes.
Yeah.
So they can't access the community, and they can't access the inpatient.
Okay.
So they fall between two stools.
So if they're in the community, they could go to their GP if they were minded. Do you know what I mean?
They could go to their GP, and the
yeah.
GP could refer them for physiotherapy.
Yeah.
And where there might be a long waiting list, they would eventually get it. Whereas in inpatient continuing care units, that may not be the case.
Okay,
yeah. And that's right. If I could hand over to somebody else just for
The regulation of mental health services, I'll follow up on that one. You're rightly so that state that our remit extends only to inpatient services in relation to enforcement, in relation to compliance of the services. We register them. It doesn't extend beyond that. Inpatient, although the inspector has the right to visit anywhere mental health services delivered, we have no enforcement or powers in relation to that. We have advocated, and as we have today in one of our recommendations, that our powers be extended. It would give us more powers in being able to look then and to address a lot of your questions today here that a lot of the ministers and senators have asked of us that we're not able to answer because we don't have that full picture of a pathway of a patient through a mental health services. We're only looking at a very small portion of that 10% of people that actually are inpatient, so we don't have oversight of the rest of the mental health services where the majority of them are delivered, and that is a deficit in itself, that there is no oversight of that piece of, I suppose, a patient's journey through mental health provision. And in relation to the protection element then that you mentioned, that is a very important piece of work where we see ourselves as the safeguarding the people who are the most illest, that they require involuntary detention, and through our offices then we establish the tribunals to ensure that their rights are upheld, and that has been, I suppose, a very welcome provision for the people who have to go through that process, that they're afforded those rights and protections. Just in relation to other questions, I suppose the critical issues outside of the health remit, is that, do you mean in other departments' jurisdiction?
Is there something that you say, oh, for God's sake, if something was happening here, or isn't that a great thing that's happening there, that's something that's not in the health basket but actually has an impact? Or just...
Yeah.
I think when you mentioned it, one of the I suppose organisations that I would think have had an impact is Jigsaw, which provides primary care services for young people, and I think they have had quite an impact. They work with the CAM services, but they provide a walk-in service for young people, and they support them through whatever journey they're making through their mental health issues. And I think they have been able to provide a primary care service where possibly the HSE have had difficulties in providing.
You've made a great recovery, Doctor.
Thank you.
Senator Dolan, thank you for those questions. And in terms of one or two critical areas outside the health service that actually have a huge impact on people recovering from a mental health difficulty, really the two areas are housing and employment. And the reality is that many people who have a mental health difficulty would identify for themselves that if they could just get an adequate housing situation, that would help them to recover. Or if they could just get that support to get back into the daily life of employment or participating in the community, perhaps it'll be as a volunteer or in other ways, maybe it's as being a parent, you know. But if they could get those kind of supports, that actually that would, in their minds, would be as important for their recovery, if not more important than some of the medical treatment that they will receive. Because those, and actually, they're not alone in thinking that, because the evidence is very good for the impact of having secure housing and the impact of having employment. So, for instance, when we look at our social welfare system and we see that about 50% of the people who are on disability allowance identify mental health as their primary concern, then we know that we don't have a well-functioning mental health system, because it shouldn't be the case that people who have a mental health difficulty and who want to work don't routinely get the support that they need to get into work, and it's not routine yet. I mean, we welcome the national rollout of, under the Service Reform Fund, of support for people with severe mental health difficulties to get back into work, but that's a pilot. Clearly, that's a pilot program, and that needs to be mainstreamed. And certainly in housing, there should not be anyone in an inpatient unit in this country who's there only because they can't get a house. That's a very inefficient use of resources, and yet that is the case in inpatient units around the country, and we have seen evidence of that in the past. So those are two areas. The other area that I would highlight that maybe isn't so related to what would help people recover, but is symptomatic of the weaknesses in our system, is the extent of mental health difficulties arising for people who are in the prison system and people who are on remand. You know, where we have 40 to 60% of people on remand who have a diagnosable mental health difficulty, 5 to 10% of people in the prison system have a severe mental health difficulty. That's not the appropriate place to recover from a mental health difficulty. That's not going to help people to recover. And certainly we need to really look at the supports in the prison system and make sure that people who do have mental distress and who are within the prison system are getting just as good quality supports and are getting all the support that they need, so that their mental health difficulty isn't reducing their ability to kind of get back into the community. I think I'd like my colleague Kate to answer the question on the UN Convention on the Rights of Persons with Disabilities, which of course, you know, people with a mental health difficulty don't always identify for themselves as having a disability. But that convention has a lot of powerful messages and commitments that can positively impact on people with mental health difficulties.
Thank you, Senator, for your question. And in response to that question about compliance with the UNCRPD, it is quite clear that Ireland is currently out of compliance with the UNCRPD in that its Mental Health Act 2001 is not in line with the UNCRPD, but also not in line with the European Convention on Human Rights. And the government has acknowledged that itself in its roadmap for ratification of the convention. And we can see that in a number of ways with our Mental Health Act, in terms of voluntary patients not having very basic rights to information in terms of, you know, how long they expect to be in hospital, information around their length of stay or estimated length of stay, people who are inpatients and are detained under the Mental Health Act 2001 do not have a legal right to an advance directive, which basically means that when they are well, they can set out their wishes and preferences in terms of their treatment, and when they become unwell, that kicks into effect. People who are detained under the Mental Health Act 2001 are the only group of individuals who are actually excluded from that legal right to a legally binding advance directive. We're out of compliance in terms of not having individual care planning on a statutory footing, lack of statutory rights around advocacy services and support. So there are many areas or many provisions in our Mental Health Act 2001 that need to be reformed, need to be updated urgently to ensure that we are in compliance with international human rights standards, including the UNCRPD. In terms of our policy, A Vision for Change, it is quite clear that there are many aspects of our policy that haven't been implemented or implemented to full effect, and we can see that through MHR's most recent national consultation of people who use the mental health services. So, for example, it's been in our national mental health policy for over a decade, for over 13 years, that all individuals accessing the mental health services would have an individual care recovery plan. Over 2/3 of people who responded to our survey reported that they were not aware of having a written care recovery plan. Similarly, around key working, it's explicit in our national mental health policy that people would have access to key working, though people who are using the services are reporting, many of them are reporting that they don't have access to that kind of support. Similarly, in terms of being listened to, or being involved in decisions about medication. So there is a significant gap in terms of what's in our policy and what's happening in practice. So I would say that there is a very positive opportunity in terms of the revised mental health policy to address some of those issues and to ensure that there is implementation of the revised policy. And one of the ways that we can do that is to costed timelined action plans to ensure that there are robust monitoring review mechanisms, so we do much better this time round.
Thank you very much, Kate. Can we now move on to Deputy O'Connell?
Indeed. All right.
Thank you.
Thanks very much, and thank you all for coming in this morning.
And just before you start, Deputy, you weren't here earlier, but we're having a meeting at 12:30 with representatives from the department in relation to
the pre-ledge, is it?
Yeah. So.
Oh, I thought that was happening first this morning. That's
yeah. So if you just
got my
in case you leave
inverted.
before I remind you. Yeah.
That's all right. Well, I'll be done by 12:30, hopefully. That's all right with you.
There's no window.
It's a target.
Anyway, I think I hope I'm not going to go over ground again, but standing out to me last night as I read your opening statement, at the top of the list was governance and accountability in the health service. And I sit in the Health Committee and the Public Accounts Committee, and we've had cervical and we've had the Children's Hospital in front of us, and key to the fixing of all this, we've been told, is a change of governance structure. It seems to be the magic wand that is waved at us when something goes wrong. Now, overspends in hospitals are one thing, but if you have if you people have a serious concern about governance and accountability in mental health services, the net effect, to my mind, is catastrophic instances of people losing their lives or dying prematurely because of poor governance. So perhaps somebody, whoever's best briefed to discuss it, might outline in your experience how bad governance or weaknesses in governments can have catastrophic impacts on outcomes for patients. The second thing I want to go to, and it's just in terms of the devolution to regional bodies. And we speak a lot in here, and both myself and Deputy Durkan and Dr. Harty sat on the Sláinte Care committee, and we spoke about, community health organisations and having proper boundaries with the hospital groups. And are you saying to us here this morning that in terms of mental health, that we need, in your opinion, we need a national director of mental health steering this from the very top and then sort of filtering down that direction to the organisations? Because really coming out of this committee, we want to make it very, very clear what you want, because if bad outcomes is catastrophic impacts on families and on people's lives, well, I mean, we have to act, because it's not an accident. This is an emergency, as far as I'm concerned. In terms of, just for the doctors present and the medics present, when you have gaps in funding or you have gaps in staffing, how does it affect your approach to treatment and your approach as a professional? Are you ending up in situations, and obviously I can't outline every permutation of a situation, but are consultant psychiatrists and teams ending up in situations where they see person A at 14 years of age and they really want to do a very, very considered pathway of care for this particular individual, but because the resources aren't there, you have to kind of go to the tier 2 of the treatment, or the tier 3, where you kind of go, well, we don't have the cognitive behavioural therapy, we don't have the social services, we don't have the clinical nurse, we don't have the psychiatrists, so we'll just medicate until we can, sort of in a holding situation. I'm a pharmacist by profession, don't practice anymore, but is it a case that people, young or old, are getting suboptimum treatment just to keep them in sort of a holding position, and perhaps to what extent that's happening? spoke about, and it's very concerning, I find it really concerning, about the obviously increased demand, which in some ways is good because it's people recognising that there's an issue, and perhaps openness towards mental health is why. Maybe it's just that there's more conditions or there's more presentations. But it is very, very concerning if you have an increased demand, and although the budget, I can see, has increased, it hasn't increased at the same rate. Where I think it was yourself, Dr. McDade, where you spoke about the threshold, or maybe it's yourself, Dr. Finnerty, where the threshold, and how that makes medical professionals who are treating professionals feel, if they literally have to go, this is, in my medical, nearly triaging the level of emergency. And in terms of, I don't want to get into your personal lives, but in terms of going home and sleeping at night, when you're looking at that threshold and you're looking at funding, are you lying there in bed going, was that person actually where they should have they got over the threshold? Have I made the wrong decision? Are you being forced to make suboptimal decisions because you just have to prioritise the services to those that are in the most, at risk? The institutionalised care reference that somebody mentioned in response to Deputy Durkan's questions about homelessness, and the Trinity have the longitudinal study on growing up in Ireland, and there was some findings brought out, I think, I read something at some point, at the start of the year, I think, and the negative effects of the recession on children and families and their mental health, and I can't remember the detail of it. But if that's the case, which I'm sure it is, because it's a very well constructed study, for people living in direct provision, I think it was 15 years ago, or 13 years ago, I was working at Athlone with the Lithuanian site as a pharmacist, and I can't believe those people are still there. I was kind of telling them this will be over soon. I mean, how can anyone quantify the long-term effects on those people's mental health? If you've taken 13 years out of somebody's life and de-skilled them and taken a home off them, or taken the ability to have a home, and also all of the other issues, a lot of women there with children who are particularly vulnerable. I mean, is this, you know, the inquiry of the future is really what I'm getting at here. I just want to finish off the questions, and then I'll get the answer. The next bit I want to speak about is this separation of addiction and mental health, an international best practice. I've heard this anecdotally out in the real world, where you can't see the psychiatrist until you stop taking the drugs, or you can't, you know. And is that normal in other jurisdictions to stream these two illnesses or conditions? Because it doesn't seem in any way logical. If you're taking drugs because you're self-medicating for an underlying mental health and that issue, and then you come off the illegal drugs, we'll say, or the legal drugs, whichever it is, but then you're in limbo, your mental health need is still not met. So perhaps you could expand on that and maybe outline what the best way of sorting this out is. Another issue that's really just come to me when I'm sitting here this morning, I have a bit of legislation going through, Dolan, we'll be looking at it here at the committee, about the regulation of advertising of fake cures for people with cancer treatments. In terms of the influence of social media on vulnerable people who have mental health issues. So I'm just thinking here that if people are so bad that they will target someone who's stage 4 cancer and tell them that by standing on their head and rubbing cat's urine into their hair, it's going to cure it. Well, are people doing the same to people? Is this happening across mental health and psychiatric illness? Is there any market out there that you know of or you've come across? It's just really an aside this morning from personal interest. Is there a notable social media influence and negative impact and targeting of people with mental health illnesses, with rogue treatments, or, you know, big pharma's out to get you, or whatever? Is that prevalent these days, and is an issue in terms of providing care? Do people drop off out of the services because somebody on the internet is going to fix them and not the professionals? Thank you.
Thank you, Deputy O'Connell. Have you recovered, Dr. Harty?
I have recovered, thank you very much. I might answer, if that's okay with you, Deputy, the question about doctors and how they feel about gaps in funding and treatment. I am a psychiatrist, but like yourself, I don't practice clinically and haven't done for some time. But yes, if there are gaps in funding and if there are gaps in treatment, yes, people have told me, consultants have told me about the worries that they have had about, how do they provide a service for people when it basically isn't there. I think that an example of that might be to take somebody who has a severe and enduring mental illness, who is in a continuing care unit, and that person is capable of moving to more independent accommodation. There is a small rehabilitation team that want that person to move on and who have provided the best they can, but there is no housing for them to move on to. There is no employment or vocational training for them to move on to. There is not enough support in the community for them to live in a more independent lifestyle. And that person stays where they are. And within the continuing care unit, despite the fact that the doctors and the team feel that that person could move on. So their life is affected by the fact that there are gaps in services and gaps in funding. I think at the other end of the spectrum, the same thing happens in CAM services as well. A person who may be assessed by consultant or one of the team may be very unwell, but there is no accessible beds in the system at that particular time for that young person to be admitted. And I think that's where your point about sleepless nights and worries that that person is unwell, that young person is unwell, and the parents have to, I think somebody mentioned, the parents have to look after that child because there is no place for that person to go, no accessible place for that person to go. So yes, I think your point that yes, I think doctors do worry. I think other team members do worry about that, and I certainly think families worry.
So, Deputy, I'll take the questions that you've raised around governance and accountability and link that to the question you've asked around the experience of gaps in services. We have been very clear that we think that the absence of a mental health information system and that the dissolution of the post of National Director and the Office of the Mental Health within the HSE are negative for being able to have adequate accountability. And I think a good example of that is the statement that the HSE made in their service plan this year, where they said quite clearly that they will have to essentially make choices about providing services to some people and not providing services to others because they didn't get the full funding that the mental health services said they needed. So they're essentially saying that they have to ration services. I mean, that's what that translates as, is we will have to make choices that some people will get mental health treatment and others will not, because we won't have adequate funding this year based on what we know the demand will be. And the tragedy is that the real tragedy, of course, as you've pointed out, is that when people don't get mental health treatment, their mental health often deteriorates, they get worse, and sometimes with the very worst of outcomes. But also that we don't know, and we have no way of knowing, as far as I can tell, of how much that's going on, of who is being helped and who's not being helped, of what those decisions are. And a good example is in the emergency departments. We have a self-harm liaison service. We have admission through A&E departments. So those people who are admitted through A&E, we know that they get help. We don't know how many people are turned away from A&E. That information is not kept. So we have no idea how many people have showed up in A&E feeling that they're in distress and actually not gotten any service. That runs right through the whole mental health service, so that we don't know how many people are helped. We don't know how many people go into a mental health service who feel they need, you know, a holistic range of supports, and maybe they're only getting one type of support and not the others that they need. We have some indications from our survey of people who've used mental health services, you know, saying that they have gotten talking therapies. The findings were encouraging in that more people said they were getting talking therapies than maybe we had expected. But it's still the case that many people say they only saw one mental health professional, that within the mental health services they're saying that their experience is of predominantly of medication being the predominant mode of treatment. But we really do not have robust, consistent, regular, transparent information about what is going on in our mental health services. And of course that's worrying. Of course that's worrying. When you have hundreds of people living in high support accommodation, medium and low support HSE accommodation, and we don't know the quality of the service that they're getting, apart from the inspection reports that have been done on an, you know, on a informal basis, so to speak, in that we don't have those services regulated. So I would say what I've said to the committee in the past, which is that it is an urgent priority to get better quality, more transparent information about what is happening in the delivery of our mental health services, so that we can then attest to whether people are getting the services that they need. I think there was a question there about the separation of addiction and mental health, and I'll ask Mike.
Practice.
Yes, I think Kate can answer that question.
So thank you for raising that question, and it's a really fundamental issue where we hear consistently of both adults and children not getting access to mental health services because they have a dual diagnosis of mental health difficulties and addiction. My understanding that there are practices happening in other jurisdictions which focus very much on integration between addiction and mental health services and co-location of addiction counsellors on mental health teams, which is proving very effective. Even within the Irish context, there has been a pilot of that integration between addiction and mental health supports and co-location of addiction counsellor on a mental health team. It's the no wrong door approach that was piloted in North Tipperary, which proved to show very positive outcomes in terms of people being able to access the services they require, but also showing marked improvements in their own mental health and well-being. So I think we really need to be looking to those kind of initiatives that are happening, you know, within Ireland itself in terms of what's working, and look at rolling that out at a national level. But I think it does require a multi-pronged approach. You know, in addition to co-location of addiction counsellors on teams, which is happening in certain areas, but it's certainly not happening everywhere. There is also a requirement to increase the capacity within community mental health teams to actually support people with addictions, and that, you know, applies to across the disciplines. To also increase capacity and adequately resource addiction services so they can provide some, you know, low-level mental health support. But there are also very formal processes and protocols to ensure that collaboration and integration between the addiction and mental health services. So it does require significant investment, attention and focus to ensure that we see progress in this area.
Thank you.
Sorry, Dr.
May just to add to that, I suppose I'm a long time around. I think traditionally, when I started, addiction counsellors were on mental health teams. There was usually one or two addiction counsellors. That has continued in some areas to this day. I suppose very much we would feel that addiction, I mean, whether it's the cause of the mental illness or whether it's because of the mental illness, we feel that it does need to be addressed within the holistic way of looking at people and trying to help them. And there certainly has been a move to silo it really, and also, I mean, that sort of ties in with what I was saying too about the physical health.
Why would anyone do, like, who, if you're, as you said, around a long time, not my words, why are they doing this if it's internationally not ideal, if you have a pilot that says there's a better way, why would you do this?
I think it's probably because Vision for Change saw it as two quite distinct areas, and that treatment of addiction problems should be in the community, and they should be outside the mental health teams, and that has sort of continued. I think, and I'm hoping that in a Vision for Change review, refresh, that will be looked at again, and that there will be more holistic, more person-centred treatment, and that addiction counselling, physical health and other areas would be part of that sort of care pathway, if you like, into that.
And just to follow up there, the hundreds of people that are in high support HSE units, do we not? Are they not been is their progress not been quantified? Do those people not even have care pathways? Somebody mentioned there was no care pathway, there was an absence of care pathways, but even the people that are in institution or in high support HSE care, so people who are in places, do they not even have care pathways for getting through?
The care pathway for those people in residences like that is really through rehabilitation and recovery. Their acute need, if you like, has now gone, and it's really to move them on. No, they don't, because there aren't enough rehabilitation teams, and the teams that are there are very, very poorly staffed. There's only about 48% of there's 48% of that are teams of that recommended in a Vision for Change.
So even if you did a care pathway and it said rehabilitation X, Y, and Z way, you don't have the people to do it.
Yeah, and you don't have the
this
housing.
Is how you fix yourself.
Yeah.
We can't do it.
Yeah, we don't have the housing to do it. We don't have the vocational training.
Stay where you are.
Yeah.
Just to address the governance and accountability question and the devolution from the Commission's perspective, since the commencement of the 2001 Act in 2006, we've seen a number of iterations of governance structure within the public sector. We don't see similar within the private sector, which we also regulate. So we've gone through, I suppose, a number of different people who are responsible, and there's been occasions when we don't know who actually is responsible and accountable for, although the Act does provide for a registered proprietor, which in the case of the public sector is the Director General of the HSE, who devolves that down. And that can be devolved down to anybody that he or she deems to consider fit for the role, and can be at different levels of authority. So they don't always necessarily have the remit in relation to the funding, for example. So therefore, they don't really have the authority to exercise any change within their remit. And I suppose you asked for an example of that, and you can clearly see that within the inspection reports, and when you see the levels of non-compliance within the different CHO areas, and even within the CHO areas, you will see the disparity of compliance levels within each of those regions, which it is one service, is provided by one provider, and we have to ask the question, why in one area can you be compliant and you can people can receive a service, a good quality service, and down the road you're not receiving the same type of service, despite the fact that it's the one governor, the one commissioner of that service. And again, I suppose that's why we would ask and advocate for that we do have a National Office for Mental Health, and that they have the oversight and responsibility in relation to the delivery of the mental health services. We would also advocate, I suppose, in the area of regulation. The Act, the regulations, doesn't provide for us to have an oversight of governance arrangements, which would be unlike our sister regulator in HICWA, and also unlike other jurisdictions who do have that oversight in relation to statutory regulatory oversight in relation to governance.
Thank you.
So the Act be a responsible, accountable person, and that person, there's no actual, you know, qualifications or set out parameters for who they are and what they don't have to be medical or anything. Is that what you're saying?
That's
and they
correct.
can appear anywhere on the governance structure within the HSE.
The Act refers to a named person, the registered provider.
A named person.
And there's also, I suppose, there's clinical governance as well in relation to the clinical director has set responsibilities as well, and they don't always necessarily meet up, corporate governance and clinical governance, and that's another issue that needs to be addressed.
So the person actually making the decision could be below the pay grade of, you know, it's...
Yes.
Yeah, it's very poorly thought out, really.
The Health Act lays out very clear provisions for the registered provider of designated and residential services, where the Mental Health Act, there is nothing laid out in relation to fit for person in relation to being in charge or running of an approved centre.
Great. It's reassuring.
Thank you, Deputy O'Connell.
Thank you.
Just before we conclude, I'd just like to ask a few questions. And in relation to compliance, Dr. Finnerty, and maybe Kate Frobin might like to comment. You talk about regulatory compliance improving from small percentage points year on year. What are the areas where there is non-compliance?
Kate will.
Sure. So on inspection, the inspector is required to look at all regulations, codes of practice and statutory rules. So we actually have a very kind of comprehensive data set spanning across a number of years now, which does allow us to take a risk-based or intelligence-led approach to identifying concerns. So across most of the areas there is improvement. As Dr. Finnerty was saying, it's slow and modest improvement, but there are some areas where improvement is really lacking. That would be around areas such as premises, unsuitable premises or unsafe premises, or issues such as cleanliness of the premises. Issues around privacy, medication is still low, and around staffing, in particular around staff training. So we continue to have concerns around those areas, but as my colleague Ms Smith was pointing out, we do actually see high compliance in some parts of the country and in some sectors, and there's no explanation as to why in some areas or in some CHOs compliance should be so much lower when it is the same provider.
And in relation to, perhaps they're not Nightingale wards anymore, maybe they still are, but patients who are sharing accommodation, what regulations are there to govern that? Like in relation to housing, we have very strict housing regulations. In relation to accommodation in hospitals, then, are there regulations?
There are regulations, but it's broadly stated, I guess, that the furnishings and fittings have to be suitable to the number of residents, or that the overall environment needs to meet the needs of residents. So it's very broadly stated. There's a lot of room for interpretation within that. But as Dr. Finnerty was pointing out, we don't think it's suitable that people continue to be in dormitory-style accommodation, particularly for long-term accommodation. But there is no regulatory prohibition on that as such.
Okay. And in relation to recruitment and retention, during the hearings of the Future of Mental Health Committee, we learned that to recruit a nurse, for instance, you had to go through 25 steps between deciding a nurse was needed and actually having approval of that nurse. And if there was any gap in those 25 steps, the approval was delayed. It could be up to 18 months before you could recruit a nurse. So is that an issue, because recruitment is national rather than regional? In Sláintecare there's a proposal that there should be a regionalisation of services and that regions would have autonomy in recruiting staff as one aspect of that regionalised autonomy. Is that an issue, that it's too centralised, the recruitment and retention is too centralised?
Yeah, I don't have actual... I'm not aware of the exact number of steps or how actually long it takes, but it's certainly something that would be fed back to us on inspections, that, and we would say that a post is approved but by the time, you know, and it maybe have been approved for a few months or 6 months, but there's no sign of that person coming. And it's not just nurses, that's across the board as well, and the allied health professionals.
Because I would be aware of community psychiatric teams who are very poorly populated, not just CAMS, but community psychiatric teams who don't have a psychiatrist, who haven't had a psychologist for several years, have half a social worker, half a occupational therapist. And that leads to, obviously, a reduction in service and poor outcomes for patients.
Yes.
And prolonged waiting lists, unfortunately. And going back to Colm Burke talking about a lack of consultants making decisions, unfortunately now we have non-consultant hospital doctors who are filling the gaps, not just acting up to consultant level, but it may be the non-consultant hospital doctor is the only person who can man an outpatient, which isn't satisfactory. So how can we overcome that?
I think that's very difficult to do that. As regards the NCHDs, they are doctors in training to become psychiatrists or to become GPs, and the level of that training differs. So you could have somebody who has just started their training to somebody who is finishing their training, actually making those decisions and taking out patients and so on. Recruitment of consultants, it's very difficult to recruit consultants in an area where there are no consultants, if you get what I mean. In an area where there's an active service, where teams are well staffed, where there is good training and CPD and so on, you'll tend to attract the consultant psychiatrists, and we would see that as you go around the country. In areas where teams are poorly staffed or where they have difficulty, long-term difficulty in recruiting consultants, you find that they're the ones that not only recruitment but retention is a difficulty.
Yeah, well, I would be aware of teams where they're poorly populated. Those who are left standing in those teams burn out much quicker.
Yes.
And as a result, it's almost like a spiral. That team disintegrates quicker and quicker because of the lack of support, really. And there is an issue that staff who work in psychiatry and in other areas of medicine don't have adequate support from the HSE to allow them to work effectively and efficiently. And they burn out much more quickly.
Yes.
Are there any moves within the HSE to put in additional supports to support staff? Once you've got a member of staff, it's a fantastic resource to have, and to allow them to burn out and leave seems to be very uncaring of the employer.
I think as regards areas like training, it appears that the HSE are very willing to allow staff to go on for further training. The difficulty, back again to the spiral, the difficulty is to release those staff for training because they haven't got enough staff. You know, as you say, it's a spiral because you don't have the critical mass of staff. It's very hard to retain those that are there. Unless you put in motivating and then factors, and then when you put in the motivating factors, you find say like training, you can't release them. So yeah, it's a big problem.
And in relation to CAMS, from my own experience, you come across a lot of children who are in distress for whatever reason, but they're not necessarily needing the services of CAMS, that they're not needing a psychiatric service, they're needing a much more supportive service. But CAMS tends to be the catch-all for everyone who's in distress, which then blocks appointments and places for people who are in genuine need. So is there space, or is there a way of directing people to a more appropriate service other than CAMS, because talk therapy is generally what these adolescents need. But unfortunately, talk therapy is very difficult to get. And I suppose that goes into adult psychiatry as well, where because there's a lack of talk therapy and cognitive behaviour therapy and occupational therapy and all the other therapies that go with helping people with mental illness, the prescription pad is the easy way out, and there is a lot of unnecessary medication, I would think, prescribed because the other support services are not available.
Yes.
And how can we address that?
Yeah, I think that's true. Actually, I'm hopeful that the assistant psychologists in primary care will address some of that need, but there aren't a huge number of them, but they may well. Jigsaw, again, which I have mentioned, is one area where young people can go to get that kind of support where there isn't a serious mental illness involved. But I do agree, I've been told by nearly all the teams in CAMS that that they are absorbing everybody who has any mental health difficulties, and they sit on waiting lists, and they don't allow then for people with serious mental illness to be assessed and treated, because there is triage going on, and some areas have actually managed to get their waiting lists right down, but there's very few community services for the less seriously ill, and there they sit on the waiting lists. Yeah.
And Dr. McDade, could I ask, you have mentioned there's an urgent need for legislative change and an updating of the 2001 Act. What are the areas that you feel need to be dealt with most urgently and which are most important?
Yes, well, so firstly, the regulation of the community residences. I think it's deeply concerning that there are people in HSE supported accommodation that is unregulated, and I don't think there's other parts of the residential services in the health service that would continue to be unregulated. And in light of what we've seen in other parts of the health service in that regard, it seems to me that would be an urgent priority. Just making sure that people have the right to make decisions about their own mental health treatment. So, removing the exclusion of people with mental health difficulties who are involuntarily detained from the provisions on Advanced Health Card Directive, I think is a priority. In making sure that people who lack capacity to make decisions have their rights protected, that there's oversight for their circumstances. Currently, if you lack capacity under the current law, you can still be considered a voluntary patient, and therefore there's no tribunals, there's no requirement for independent oversight of the reasons why you're in hospital. So I think that's a very significant concern, as well as in all of those circumstances, the right to advocacy support. We have a right to a lawyer in the context of a tribunal, but we don't have the right to the kind of representative or peer advocacy to make sure that everyone who's in hospital for mental health care has the support they need to make their voice heard and to be supported to address concerns about their treatment that they have. So those are some of the priorities. I probably missed out. I know I missed out also just, voluntary patients can be quite vulnerable when they're in hospital as well. And the fact that there's no legislative requirement to provide voluntary patients with information is concerning. Oftentimes, people who are voluntary, they may not even be sure about their status. They may not be sure if they're voluntary or involuntary. And they won't necessarily know about the provision of an advocacy service or anything, other things that might be their rights when they're in services. So that would be another one. And Kate might point out if I've left out anything.
No, I think you cover the main provisions. Maybe just to add, you know, the importance of placing individual care and recovery planning on a statutory basis, so people actually have a legal right to that kind of care, recovery planning, and also the importance of introducing specific children and youth principles into the Act, so that there is particular consideration for the voice of the child and children and young people being involved in decisions about their care and treatment, and specifically to address the issue of age of consent when young people go into hospital for mental health care and treatment. Currently, those aged 16 and 17-year-olds are not presumed to have capacity to give consent to admission or to treatment, and it's really the only area of the health sector where that exists. In every other area of the health sector, 16 and 17-year-olds do have a legal right to consent to their health care. So I think that's another area that really does need to be urgently updated.
And as our health system improves and our population ages, dementia is a really growing problem. And dealing with patients who have dementia and can no longer live at home, are there plans to develop dementia services within our health services specifically? Because quite often people with chronic psychiatric illness are housed or accommodated with people who have dementing illness, and quite often that can be a real difficulty in managing those two groups. Are there specific moves to provide specific dementia services within our psychiatric services?
There are some already. Some of the approved centres are specifically for people with dementia and would provide specialist services under the auspices of the old age psychiatry teams. I can't think offhand how many of there are at the moment, but certainly yes, that a large part of the work of the old age team certainly would be around dementia care.
And is that been specifically funded?
No, it comes onto the mental health budget. Yeah.
Okay.
And Deputy, I wouldn't be in a position to have information for you on dementia service, but more widely, there's a need to make sure that there are adequate mental health services integrated, as you mentioned, in terms of sláinte care and implementation of sláinte care. Sláinte care is relatively light, I would say, on mental health, and there was a rationale for that insofar as there was an anticipated review of a Vision for Change. A Vision for Change 2, or whatever it's going to be called, needs to be fully part of the sláinte care implementation, and it needs to be conceived of as being part of sláinte care implementation. But also, the sláinte care reforms are not going to work if mental health isn't integrated into those. And I would give the example of the GP situation, the new GP contract. The GP contract, and I've only seen news reports of this, but refers a lot to support for chronic diseases. But we know, for instance, in the case of diabetes care, that the costs are 50 to 75% more for caring someone with diabetes when their mental health aspects of that are not being addressed. So unless let me put it this way, I would encourage the Health Committee to be looking out for mental health as an issue in all of the implementation of the health service reforms, because unless mental health is being integrated in all of those locations, then it's going to be a much, much more expensive system than it needs to be.
Okay. And just one, sorry, Dr. Smith.
Can I just add, to follow on from Ms Mitchell in relation to the 2001 Act, the reform of it, just to add, we concur with everything she said. All those areas just definitely need to be addressed. But in addition, the whole area which I addressed with Deputy O'Connell, the whole registration section of the Act needs to be addressed. It's the section of the Act, Part 5, is taken from nursing home legislation, from the 1990s, so it needs to be fit for purpose for modern mental health services to address the registration and regulation of mental health services in a modern era.
And just one final question then. There is now public debate on decriminalisation of cannabis. And we are all aware that cannabis can cause serious mental health issues, precipitate psychosis, demotivate young people because of the side effects and addictive qualities of cannabis. Have you any opinion on whether that decriminalisation of cannabis is something which should be promoted or resisted?
I mean, I take your point that cannabis can be associated with serious mental illness, but also people with serious mental illness may go on to self-medicate using something like cannabis, not only cannabis, but something like cannabis. So I suppose in any decisions that are being made as to whether to decriminalise cannabis, would have to look at the evidence for that very, very carefully, that and weigh up the risk on a population base to decriminalising it. Certainly on an individual basis, and certainly I would have seen people who in my past life who certainly would have had major difficulties because of cannabis use. So I think it needs to be thought about very carefully.
Can I ask actually a question on that?
Yes,
I forgot about all that. In terms of studying other populations and methods in terms of Portugal and that, is there any body of work been done by the College of Psychiatrists here looking at, we say, the Portuguese model and the impacts on the population? You don't have that information. And I suppose, in your professional opinion, as someone who's been around a long time, the impact of, I suppose, would it be your professional opinion if there was magical powers within a particular compound that's been around for generations? Would you think they may have been noticed before now? I'm very concerned about a lot of the claims being made. And while I am very much pro very compassionate approach to drug use in terms of the combination, as we discussed earlier, the links between addiction and mental health. But you know, there's almost a claim out there that you wouldn't need any of the other tablets if you had cannabis. I mean, it just seems to be there's a narrative out there, and I think a lot of us are very concerned that. I spoke about the Kardashian effect last week, but very much concerned about the erosion of the good work that professionals like yourselves has done over the year, and that some celebrity whose opinion is equal to a body of evidence that's out there. I find it very, very concerning, not just in this case, but in every case of medical treatment.
Certainly, I wouldn't think cannabis was a treatment for mental illness. I'm not any, I have no expertise at all in any of the other illnesses that cannabis has been suggested for or linked with. So I couldn't really answer. All really that I know is that there is an association between cannabis and mental illness and serious mental illness. And so I think we need to be very wary about decriminalising.
Thank you.
Thank you very much, Dr. Finnerty. So that concludes our proceedings for this morning. So on behalf of the committee, I'd like to thank you from the Mental Health Commission, Kate Fowen, and Dr. Finnerty, of course, and Rosemary Smith, and from Mental Health Reform, Dr. McDade and Kate Mitchell. Thank you very much for your attendance. We are now going to adjourn the Health Committee until the 12th of June. No.
cervical check.
Oh, excuse me. We're going to suspend for a few moments to thank you. To hear an update from the department in relation to the cervical check tribunal. Thank you very much.